I'm Sarah Hegab, and today is our Pulmonary Hypertension Symposium. And so the way that we thought we'd structure the day today would be that things are a little bit flipped. So the first hour is going to be an update on concepts and controversies in pulmonary hypertension, so it's a little bit more pulmonary based. And then our second hour is going to be a case study where we'll break off into small groups and have small group discussions, and that will be around an ICU case. So just a little bit of a flip-flop. So disclosures, our pulmonary hypertension program receives grant support from several pharmaceutical companies, and I do occasionally speak for Bayer and am a member of their advisory board. It doesn't affect the content of this talk, though. So, as all of you are aware, we were granted Pulmonary Hypertension Comprehensive Center Accreditation this past year, which we really couldn't do without the support and help that we get from the division, from our colleagues, from our fellows. So thank you all for helping contribute to making that happen. So the objectives of today's talk are a little bit different than what we've traditionally done in our PH talks. What I'd like to talk about are the updates or the ideas around changes in our understanding of the pathobiology of pulmonary arterial hypertension, current and potential future treatment paradigms, and the idea of precision medicine in PAH. So, it's well established that there are genetic deficiencies that are associated with the development of pulmonary hypertension, with the most common genetic mutation being in the BMPR2 mutation. And so a question comes up regarding whether asymptomatic offspring of someone who is a carrier of the mutation should undergo genetic testing. So should we kind of test all of these people? And the idea is that if we think about the pretest probability of someone who is an asymptomatic offspring of having PAH, the pretest probability is only about 1 in 10 or 10%. And the reason is that even if they have a 50% chance of inheriting the gene, there's a variable penetrance of the gene, where only about 20% of patients will actually develop disease. And so that's important and relevant because it's on your boards, in that they may show you kind of this inheritance pattern and ask you what the penetrance of the gene is. So it's about 20%. Back to whether we should test people in a real-world setting. If we decide to move forward with genetic testing, and this asymptomatic person is found to be negative, then their risk of developing PAH falls down to that of the general population, which is about 1 in 500,000. If a patient who is this asymptomatic offspring who starts off with a pretest probability of about 10% is found to be positive for the mutation, then their post-test probability is about 20%. And so this difference of 10% increase in risk of developing disease really raises the question of whether we should perform genetic testing in all of these patients, given that there isn't a large difference between the pretest and post-test probabilities. While we know that BMPR2 mutation is a very well-established cause of genetic or heritable PAH, we're also learning that there are other genes that are implicated. And the one that I'm going to talk to you about today is the EIF2AK4 gene, which is a gene responsible for endothelial translation initiation factor. And what we know about this gene is that it's found in 100% of patients who have PVOD or pulmonary capillary hemangiomatosis that is familial, and it's found in about 20% of patients who have sporadic PVOD. This was a study that aimed to classify or identify a genotype-phenotype kind of association with this gene. And so what they looked at is a group of patients, a large group of IPAH patients, 864 patients, and 16 patients with PVOD, and then did whole exome sequencing to really see if they had this mutation. And what they found was that about 30% of patients with PVOD had this mutation, and 1% of patients with IPAH had this mutation. But what was really fascinating was that if a patient with IPAH had this mutation, and you look down here, so these were people who were biallelic, and this represents carbon monoxide diffusion. These patients had much, much lower carbon monoxide diffusion than patients who had PAH but did not have this mutation. Furthermore, when they looked at their CAT scans, these patients were more likely to have septal thickening, mediastinal adenopathy, and so had characteristics that were very similar to patients with PVOD. And that raised the question of whether we're thinking about PVOD and PAH as two separate entities, when perhaps they may represent a continuum of disease and there may be more overlap there than we think. The other possibility is that these were patients with PVOD who were initially misclassified as IPAH, but they actually have PVOD. The other important thing is that the patients who were found to have this mutation had much worse survival and were diagnosed at a younger age. And so there are implications in terms of prognosis depending on the type of mutation that you have. The idea behind how pulmonary arterial hypertension develops is that it's likely a combination of things. There are likely, in a genetically non-susceptible individual, so somebody who doesn't have mutations, there are epigenetic changes that they're exposed to over time, in addition to probably environmental factors, so either an inflammatory insult, hypoxia, a drug or toxin, that leads to the development of PAH. This process is accelerated in a genetically susceptible individual. And so if this sounds similar to kind of the two-hit theory that we hear about in malignancy, and there are many similarities between the pathogenesis of PAH and the pathogenesis of many tumors. And so again, there's this evolving understanding that maybe there's more to, or more similarities with cancer than we initially thought. I thought I would talk to you a little bit about microRNAs and how they regulate gene expression. And the reason this is important is that microRNAs are a big hot thing right now. You'll see them in a lot of studies and in a lot of articles. And I thought just understanding what they were and why there's such interest in them would be really important, not just for PAH, but in the development of other diseases. So what are microRNAs? MicroRNAs are small, non-coding RNA molecules that are about 20 to 22 nucleotides in length. And what they do is they silence RNA and they regulate post-transcription gene expression. And so if we look at our graph here, or our figure, and see how this happens, this green area here is the nucleus. There's a protein that will export this hairpin kind of primary microRNA, so it's a precursor to microRNA, and it takes it out of the nucleus and into the cytoplasm. What happens is there's an enzyme that then cuts off this hairpin loop, and so you're left with this double-stranded RNA molecule. The top strand will bind to protein, forming this microRNA protein complex. And the bottom strand then kind of is lost. It degenerates and is lost. So now you have this unit here where you have a protein and you have a microRNA bound to it. What happens is that this microRNA protein unit will bind to messenger RNA, the nucleotides of messenger RNA, and will affect the messenger RNA's ability to be translated into protein. So you can imagine the presence of various microRNAs will affect protein synthesis and can either upregulate or downregulate the expression of different genes and production of protein. Is that clear so far? Okay. And so what we know about microRNAs and for example, RV hypertrophy is that to move from RV hypertrophy to RV failure, you get variability, or you get differences in the microRNAs that are being expressed. So if you upregulate some, then you progress from RV hypertrophy to RV failure, and if you downregulate others, the same will occur. The reason this is so important is that this presents potential therapeutic targets for treatment, right? So if we can identify certain microRNAs that are implicated in disease development and we can stop them or upregulate or downregulate depending, then that affords an opportunity for therapeutic intervention. So many of you have seen this slide before, and this is meant to represent what the current concepts and mechanisms in PAH are. And so what you see on the left side of the screen is a healthy blood vessel, and it progresses to this unhealthy pulmonary artery or arteriole that's undergone vasculopathy. We used to think that there was chronic hypoxia would lead to endothelial dysfunction, and then you had dysregulation in various mediators, and that's how pulmonary hypertension developed. But what we're learning is that there's many, many other mediators involved outside of the endothelium. There are epigenetic changes that happen in the intimal layer as well. There's inflammatory mediators that have been implicated, and again, the reason this is so important is that all of these are being looked at in clinical trials as potential targets of therapy. What you're seeing here is a cross-section of an arteriole of what is classically pulmonary arterial hypertension. So there's vascular remodeling. You can see the top arrow is pointing to this very small, narrowed arteriole. You see smooth muscle hypertrophy, medial thickening, and then on the bottom here where the arrowhead is, you can see the characteristic pathognomonic plexiform lesion that is associated with PAH. We also know that in PAH associated with collagen vascular disease, if you look at these patients histopathologically, what you'll find is there's still the fibrosis that we see associated with PAH, but you also see all of these blue cells. And so that's a lymphocytic infiltration in that area. And so suggesting that perhaps patients with PAH secondary to collagen vascular disease, a big part of their disease is being driven by inflammation in addition to all of the other mediators that we know about. Then we move on to the veno-occlusive disease-like pattern, where you get similar findings to what you see in PAH on the arterial side, but you see it on the venous side. So you get pronounced thickening of the venous intima, you get obliteration of the lumen. What's interesting about these patients, though, is that they do develop vasculopathy on the arterial side as well as the disease progresses, but they don't have the characteristic plexiform lesions that we see in IPAH. So we're not really sure whether PVOD and PAH or IPAH are really separate entities, or whether perhaps they represent a continuum. Whether whether they may be related genetically. We see that there are some genes that are shared between the two. Whether patients may start off with PVOD and progress to developing an arterial vasculopathy, or whether the opposite is true. Biomarkers are another area of interest in pulmonary hypertension. The only FDA-approved biomarker for use in PH is BNP and proBNP. And so the question is, are there other biomarkers that can be used to monitor disease development, disease progression, and response to therapy? And I'll just go through a couple. We know that angiopoietin-1 is associated with PAH and is implicated in the development of the disease. But this study, for example, found that there were no differences in any of the groups that were evaluated in terms of using angiopoietin as a biomarker. I think one of the most interesting things was this study here that actually looked at many biomarkers. And what was fascinating is that if you look at the top three columns, and I know it doesn't project very well, but that proBNP, elevated levels of proBNP, low levels of von Willebrand factor, and really interestingly, low levels of total cholesterol were associated with higher mortality in patients with PAH. And while HDL levels were associated with worse functional class, they didn't really have a bearing on mortality. And the question is, what does cholesterol have to do with pulmonary hypertension, and why would these patients have a higher mortality, or it be associated with a higher mortality? Could it be that these patients are not, it's a marker of malnourishment, so they have bowel wall edema, they're not absorbing nutrition, they're nutritionally deficient? Could it be that we know that lipid metabolism and inflammation are very closely tied together, and so these patients tend to have more inflammation, and that might be why we're seeing that? It's not really clear, but it is interesting. In terms of exhaled nitric oxide, which shows some promise, patients with lower levels of exhaled nitric oxide have worse prognosis. And that makes sense if we think about how the role of nitric oxide in the development of PAH. Obviously, none of these are ready for prime time. None of these have been validated in a larger cohort of patients. And so we're not yet able to use them, but lots of research is happening around various biomarkers that we could use in PAH monitoring. We've traditionally thought of PAH as a disease that affects the pulmonary arterial vascular bed, and just that vascular bed with the resultant consequences on the RV. But should we be thinking about PAH as a more systemic disease that affects the body more broadly? This was a really interesting study where they took muscle biopsies from patients who had normal healthy controls and compared them to patients who had pulmonary arterial hypertension. And what they found was, they found several things. What they found was, if you guys remember from medical school, the difference between type 1 and type 2 muscle fibers. So type 1 muscle fibers are the ones that are responsible for contraction that is associated with kind of endurance activities, whereas the slower twitch fibers are the type 2. And patients with PAH had lower levels of type 1 fibers, higher levels of type 2 fibers. But what they also found was that these patients had a shift towards anaerobic metabolism that was not present in healthy controls. So these patients had much lower levels of pyruvate dehydrogenase and much higher levels of LDH. And so their metabolism was shifted towards anaerobic metabolism, and they had lower levels of oxygen consumption at maximal exercise, which is something that we see on their cardiopulmonary exercise testing. When they looked at the number and structure of the mitochondria in these patients, they also found that they were drastically lower in PAH patients. So again, these patients have abnormalities above and beyond what we see in the pulmonary arterial bed, affecting the other parts of the body. What we also know is that, so kind of piggybacking on that, is that we just talked about how these patients have lower levels of PDH, and they also, to make matters worse, produce too much PDK, which is pyruvate dehydrogenase kinase. And so this was a study that looked at, well, can I lower the level of this enzyme so that I could raise the PDH and have these patients metabolize oxygen normally, so that I could shift them back towards aerobic metabolism. And what they did was that they did a small clinical trial in 20 patients with PAH who are on various forms of therapy, both oral and parenteral, and did a dose-finding study where several doses of DCA were tried. What they found was that the highest doses, neuropathy developed in all of the patients, and so the drug had to be withdrawn, but at lower doses, there was improvement in mean PA pressure, PVR, and 6-minute walk distance, all to a statistically significant degree. What was also interesting was that we start to see that there are variations in response to therapies depending on genetic variations. And so that we'll talk about that later in terms of the implications of these genetic variations on precision medicine. And so far, what we've talked about is, in the pathobiology of PAH, is we've talked a little bit about the genetics, and both of those genes are board testable because they're well established to be implicated in PAH. We've talked about the two-hit theory and the similarities of PAH and malignancy. Multiple mediators and pathways that are implicated in the development of the disease outside of the endothelium. We've talked about how PAH and PVOD might perhaps be a continuum of disease. And PAH is a systemic disease with multiple other mediators and therefore potential targets of therapy. So what we'll talk about now is current treatment paradigms in PAH. So this is a different schematic outlining the 5 groups of pulmonary hypertension that we're all familiar with. And what you see on the left side of the screen are group 1 and 4 disease, which have defined, established, FDA-approved therapies. So these are where we use our pulmonary vasodilators. So group 1 disease, and then group 4, where we know that if patients have operable disease, the ideal treatment, if the patient can undergo it, would be surgical pulmonary artery endarterectomy. And if they have inoperable disease, we have an FDA-approved medication for those patients, which is riociguat. For the patients on the right side of the screen, so group 2 patients, so PH associated with left heart disease, group 3 with lung disease, and then group 5, which is a miscellaneous kind of basket of diagnoses that don't fit really well or cleanly into any of the other groups. We have less information about what we should do, and probably more information about what we shouldn't do, in that studies have not supported the use of pulmonary vasodilators in most subgroups that belong to these groups. This is also another slide that you've probably seen before, outlining the 3 pathways and therefore drug targets that we currently have for pulmonary hypertension. So we have the nitric oxide pathway, the endothelin pathway, and the prostacyclin pathway. And the problem in patients with PH is that they don't have enough nitric oxide, they don't have enough prostacyclin, and they have too much endothelin. So our goal is to raise nitric oxide and prostacyclin levels and reduce endothelin levels. In the nitric oxide pathway, we have PDE5 inhibitors, so sildenafil and tadalafil that we use pretty commonly, but we also have soluble guanylyl cyclase stimulators, which is riociguat, which is a first-in-class kind of novel drug that targets that pathway. The way that you can think about it, there's some thought that riociguat may be more potent than tadalafil or sildenafil, because if you think about sildenafil as kind of plugging the sink and raising nitric oxide levels that way, riociguat is like turning on the faucet and plugging the sink at the same time, and so there's more nitric oxide made available. Currently, there are clinical trials looking at that exact question of whether that drug is more potent than the other two. For the prostacyclin pathway, those are our parenteral, whether it be IV or sub-Q, inhaled, and currently oral prostacyclin tablet, which is Orenitram. And those act on many different prostacyclin receptors, which is how both the beneficial effects of the prostacyclin are mediated, as well as many of the side effects, because we have prostacyclin receptors all over our body. So a lot of the side effects that patients experience are due to stimulation of those receptors outside of the lung. Selective the endothelin pathway is where we have our endothelin receptor antagonists, so bosentan, ambrisentan, and macitentan. Bosentan was the first approved in this pathway. It was non-selective, so it acted on both A and B receptors, but the problem was there was a lot of hepatotoxicity associated with this drug. The next drug to come along is ambrisentan, which we use much more commonly now, that we don't really have a lot of patients that are still on bosentan. Ambrisentan is a selective antagonist, and so acts only on one of the receptors. Doesn't have as much hepatotoxicity, but probably isn't as potent as bosentan. And the most commonly used drug that you'll see patients on right now that we're using quite frequently is macitentan. The benefit of macitentan is that it's non-selective. It antagonizes endothelin at both A and B receptors, and it has the added benefit that it doesn't cause the hepatotoxicity that bosentan causes, because it doesn't inhibit bile salt transfer, which was the mechanism by which the hepatotoxicity happened. And so it's been a very kind of exciting 30 years in pulmonary hypertension in terms of the number of therapies that have become available. Patients are living much longer with much better quality of life due to the medications that have been approved, with epoprostenol or Flolan initially approved in 1996, and then all of these drugs that I just went over, kind of with the most recent being in 2015. What you'll notice, though, is that all of these drugs, again, only act on the endothelium, and we know that there's so much more going on outside of the endothelium in the pathogenesis of PAH. The REVEAL registry is a U.S. registry of patients with group 1 pulmonary hypertension with its French counterpart, which is the French National Registry. And in both of these registries, we know that patients are diagnosed at late functional class. So most patients are diagnosed between functional class 3 and 4. The reason this is so important is that we know that mortality depends on your functional class at the time of diagnosis. So if you're diagnosed sooner at a lower functional class, your chance of survival is much better. And so trying to shift this towards earlier diagnosis really does have implications on how well or how poorly these patients do. The reason that I bring up functional class and kind of wanted to focus on a little bit is that this table from the ESCER Guidelines from 2015 really highlighted that the way that we traditionally have approached treatment of pulmonary hypertension is that the choice of agent depends on functional class at the time of diagnosis. And so you can see here, it's a busy slide, but what you can see here is that in functional class 4, we have 1A recommendations that those patients should be started on the most potent drugs that we have, which are IV prostacyclins, with various kind of recommendations with regards to oral therapies, or which oral therapy, in functional class 2 and 3. What the guidelines added last time that you're actually going to see more and more, and I know the fellows are familiar with this table because it's in the template, and we added it to the template recently. The reason that we decided to add it was that we risk stratify patients in terms of their risk of one-year mortality based on these parameters that you're seeing here. So whether someone has heart failure, the rapidity that their symptoms are progressing, whether they have syncope, their functional class, 6-minute walk distance, exercise testing, BNP, imaging, and hemodynamics. If patients are in the low-risk category, or most of their parameters are in the low-risk category, that patient has a less than 5% one-year mortality. In the intermediate risk, it's 5 to 10, and in the high risk, it's more than 10. And so what this does is it highlights to us how aggressive we need to be with treatment. What we're likely going to see in the next iteration of the guidelines this fall, based on what was discussed at the World Symposium, is that these two kind of tables are going to be married, in that patients who are at high risk, that recommendation for prostacyclin is still going to stand, but that intermediate risk patients, we're probably going to see a very strong push that those patients are started on 2 drugs up front so oral combination therapy, with patients at low risk being the ones that are perhaps being considered for monotherapy. But there is a push overall from what we're seeing from several studies that targeting more than one pathway up front together results in better long-term outcomes for these patients. And so I do think that we are likely going to see a shift towards that practice pattern because of this.
Sarah?
Yeah.
How do you determine which category they fall in? Because I imagine the patients that have 1 from a low risk, 2 from intermediate risk, and perhaps maybe 1 from a high risk.
So it's tricky. What they're trying to what we haven't been able to achieve, and the Europeans are really the ones that are working on this significantly, particularly the French, is scoring this. So not just weighting each of these and scoring it, and then having that be integrated into our decision making. Right now, if we look at the REVEAL risk score, which we know we can use to calculate mortality, there are some elements to the REVEAL risk score that aren't changeable, like gender, for example. Whereas these are the modifiable parts of the REVEAL risk score, and all of these factors go into it. And so I think we are going to hopefully be headed to a time where we can weigh this a little more differently. Because I think if you have a cardiac index less than 2.5 means something different than you're walking less than 400 meters, right? And so I think we will likely see that.
So of the different measures that you have, the one that's most clearly objective is the BNP. How reliable is that in terms of application?
So there's a very strong association with higher BNP levels, and in this subgroup of patients being associated with higher mortality, with a reduction in mortality when targeting normalization of BNP.
So the numbers are good, and
Yep.
you rely on those a lot. Because consistent walking is objective, but it can vary for lots of reasons.
Sure.
And whether they have syncope or not, or some of these other things are kind of less clearly objective, but that's a number that's important. So you're saying the green is monotherapy and the yellow?
Probably.
I mean, that may change in the future.
Yes.
Like you said. And then right now it's a couple of drugs for the yellow,
And then the high risk get prostacyclin, yeah. I think what we're doing now, and I get this question a lot from the fellows who are rotating with us, is which patient are you starting on dual upfront therapy and which patient are you just picking one? And I think we were doing this in our minds, where we're kind of risk stratifying patients based on this, but I think that there's going to be clear guidelines that then are going to solidify the recommendations.
towards using more drugs earlier.
Yes. Mm-hmm. And there are studies now looking at using triple combination upfront therapy. So if you have these 3 pathways that you could target, why not target all of them at the same time and seeing whether that has, right, if there's a difference. Mm-hmm. So of the treatment options that I've discussed, so pulmonary vasodilators specifically, what we're really talking about is reducing the afterload on the RV, right, by dilating the pulmonary vasculature. There's a lot that happens, though. So this is a representation of the RV. And what we see is that due to the increased afterload, there's increased wall stress on the ventricle. And that leads to asynchrony or dyssynchrony between the left and right heart, changes in oxygen delivery and energy metabolism like we talked about in that skeletal muscle study. And there's neurohumoral activation that also occurs. All of these things lead to oxygen inefficiency, reduced pump function. Initially, the RV is able to maintain cardiac output, but eventually will dilate, leading to increased wall stress, and it's kind of this vicious cycle. And so some questions are, or some thought is being put around, well, I'm targeting the wall stress based on the drugs that I have, or using the drugs that I have to reduce afterload. What about the consequences of wall stress? So should we think about cardiac resynchronization in these patients? Should we think about medications that act on the neurohumoral changes that occur? And so if we look at PAH with it leads to or causes an increase in RV afterload, we know that results in overfilling of the RV as well as dyssynchrony. We treat overfilling with diuretics, right? That's how we modify our preload. All of these things will lead to decreased RV function, decreased cardiac output, which will result in sympathetic nerve stimulation and stimulation of the renin-angiotensin system, leading to RV remodeling, progression of RV failure, and eventually arrhythmias. So when we have patients who are on Lasix, for example, and we add aldactone, the idea isn't just to enhance the diuretic effect. The idea is really to target this mechanism here with the renin-angiotensin system, or the hyperaldosteronism that these patients may have. Sympathetic overactivity, we know, is present in both animal models of pulmonary hypertension as well as human models. And so it makes it an attractive target to potentially treat. And so this was, and I included this, this was an animal study looking at renal denervation in pulmonary vascular remodeling and PAH. The reason I included it is that it was the precursor to the pulmonary artery denervation studies that were done in humans, and also to talk a little bit about we're only as good as what our animal models are and why so many things have been tried in the lab, but then they don't pan out when we try them in humans. And so two common animal models that are used in pulmonary hypertension are the monocrotaline model and the Shugan hypoxia model. And what happens with monocrotaline is that they administer monocrotaline to mice or rats. The monocrotaline is a very toxic alkaloid agent that will result in the development of vasculopathy. What you see in Shugan hypoxia is that there is a VEGF receptor that's blocked, and then the animal is exposed to hypobaric hypoxia. And again, you can see this vasculopathy that develops. You can also see that there's differences between this picture and this picture, where the bottom picture, the Shugan hypoxia model, actually shows you much worse vasculopathy than the one you're seeing on top. And so different animal models will develop pulmonary hypertension to varying degrees that is different than what we see in humans. We also know that not all of them will develop RV failure. So if you're trying to assess RV responses to the development of pulmonary hypertension, you may not be able to depending on the animal model that you're using. What they did in this study was that they took these mice and then so they induced pulmonary hypertension and then they denervated their renal arteries. And what they found in both of them was that there was reversal to a degree of the vasculopathy that had developed. What you also see is that the vessel wall thickness, the medial thickness and the intimal thickness all was reduced, and you had a higher number of what we call free open vessels, so non-obliterated blood vessels in both models. If we're trying to target the sympathetic nervous system, the drug, or a drug that we have available, or a class of drugs, is beta blockers. And traditionally, we've thought beta blockers must be bad in pulmonary hypertension, right? If we think about cardiac output equals stroke volume times heart rate, if these patients have impaired stroke volume, they need a heart rate in order to maintain a cardiac output. And this was kind of further solidified by a study in the early 90s that showed these patients do really bad, or badly, with beta blockers. And so beta blockers were shunned for a really long time. More recently, we have beta blocker studies specifically using Coreg in these patients, and we found different results. And what we're seeing in several studies is that actually RV ejection fraction improves, RV stroke volume improves, and the end diastolic volume of the RV is reduced. So we know that they're at least safe, possibly beneficial. This was a study that showed actually 6-minute walk distance in patients on beta blockers improved, both at 3 months and 6 months. And so I think the fear of beta blockers in this patient population, while we do get the reduction in heart rate that can affect cardiac output, there's probably other beneficial effects that we're seeing due to the impact on the sympathetic nervous system that kind of mitigate that effect. That doesn't mean we don't use them cautiously in this patient population, but it's probably safe for them to be on beta blockers.
So I think that one of the differences is you should be careful with PAH and RV that's hanging in there or RV failure.
Right.
So beta blockers are bad for RV
Decompensated.
failure. But there probably is some benefit in a patient that has some RV dysfunction and RV enlargement, but the RV is still able to tolerate the pressures.
So if we can suppress the sympathetic nervous system and perhaps see some benefit, is there any way that we can stimulate the parasympathetic nervous system and get the same improvements? We know that so this was essentially a study looking at PVDomics as an inhibitor of acetylcholine esterase, wondering whether if we raised acetylcholine esterase levels in these patients, whether there would be benefit. And so this was also another animal study that showed reversal of vasculopathy in patients with in the rodents that received PVDomics, again with reduction in media thickness, intimal thickness, and degree of vessel occlusion in the treatment group. And so what we've talked about is that there are, as a result of the persistent RV afterload or the high RV afterload on the right ventricle, there are molecular changes that occur in the RV. There's electrical remodeling leading to a prolonged action potential. So that's why these patients may get bundle branch blocks. And you see a metabolic shift towards increased glucose oxidation. And what happens is that there's ventricular dysynchrony, both intra, so within the RV, different parts of the RV are not contracting at the same time the way that they should. And then if we compare the RV to the LV, there's dysynchrony between the two ventricles. And so all of that will lead to electrical uncoupling, okay? Or when you hear RV-LV interdependence, there's this uncoupling that occurs between both ventricles. And what that means is, and I'll walk you through this, it's much simpler than it looks, but basically what you're seeing with all of these colored lines are different parts of the right ventricle and the left ventricle. So the left ventricle is this bottom purple line, and what I want you to just pay attention to is the red line, which is the RV, the basal RV. And you can see that the peaks of all of these lines are happening at around the same time, meaning all parts of the right ventricle and the left ventricle are contracting together, okay? What you see happens with uncoupling is that the left ventricle is still contracting when it's supposed to, but then you have a delay in when different parts of the right ventricle are contracting, and furthermore, they're all contracting at different times. And so this raises the question of whether resynchronization therapy in this patient population could be of benefit. There are some small studies that have been done that suggest benefit, but larger studies are needed to kind of validate those results. And so we've talked about treating wall stress, so our pulmonary vasodilators and the 3 pathways. We've talked about combination versus monotherapy based on risk assessment. And we've talked about treating the consequences of wall stress. So use of beta blockers, perhaps there's a role for parasympathetic system attenuation, perhaps there's a role for cardiac resynchronization. And we've talked about treating metabolic causes and sequelae of pulmonary hypertension. And so to shift a little bit towards the idea of precision medicine. So really, has the time come to move towards precision medicine in this patient population? And this was a study that looked at treatment response and found that there were variations. So the endothelin-1 pathway gene variants predict clinical response to endothelin receptor antagonists. So if you can imagine is there a way that you could have a patient in your clinic where you could draw a blood sample and know before you start them on any therapy which drug they would respond to and which combination of therapies they may respond to? And so this has led to a very large, several tens of $1 million NIH kind of initiative called the Pulmonary Vascular Disease Phenomics, which is in short called the PVDomics Study. And what they're looking at is pulmonary vascular disease in general, but pulmonary hypertension specifically, and taking a group of patients and doing what we call deep phenotyping. So looking at their genomes, their transcriptomes, so microRNAs that we talked about, looking at their proteomes, biomes, their clinical parameters, so imaging, their chemistry, and their cardiopulmonary physiology, and seeing if we could further classify or further better understand our subgroups of pulmonary hypertension. Because right now, we have a large group of patients that are categorized as group 1, and we already know that within that subgroup, those patients are not, it's a very heterogeneous group of patients. And so if there's a way that we can classify them and understand these groups differently, this may lead to much, much better therapeutic approaches for these patients. And so it may mean that we have more accurate and meaningful disease classification of pulmonary hypertension subtypes. It'll improve our understanding of pathobiology of pulmonary vascular disease. We'll be able to characterize treatment responders and non-responders, and perhaps predict response to therapy based on deep phenotyping. Questions? Mm-hmm.
I guess one of the things that I can struggle is like these patients have all medical problems, and you see these patients when we see these patients undergoing transplant workup, and even when we see these patients just enough to sometimes these patients need like is there any way to standardize them for the risk of having complications when they undergo interval sedation, like if the patient with PH only but no right ventricular dysfunction, are they safe to go conscious sedation, or they
Sure.
See if the patient pulmonary hypertension and right ventricular failure or cardiac index? Is there any way that you can standardize those patients?
So there isn't kind of a one-size-fits-all approach, but I think ultimately the condition of the RV is what's most important. The condition of the RV, the severity of the elevation of the RV or the right-sided filling pressures. The reason that we worry about these patients in the perioperative period or with conscious sedation is that when we give sedatives, there's a reduction in their preload, right? They venodilate and they lose preload. And in somebody who requires high filling pressure to maintain a cardiac output, that's what leads to the hemodynamic decompensation. It's probably why a lot of patients that we share, we suggest if we really need a test, and it's absolutely imperative that they have it, that we have hemodynamics beforehand so that we can help risk stratify them. It doesn't mean that they can't undergo various procedures. We had a patient who is on prostacyclin who has a very, very weak RV who came in and required emergent surgery last week. But it meant that she got admitted to the unit, got a PA catheter in advance, that there were multidisciplinary meetings kind of to discuss hemodynamic management intraoperatively. And she did fine. But I think it's a case-by-case approach, and it hasn't been standardized yet. Mm-hmm.
I have two questions. One's a simple classification question, and one relates to what you just talked about. The simple classification question is when you presented the different types of PH slide, in group 1, you had listed connective tissue disease, and in group 5, you listed vasculitis. Can you tell me what you mean by that? So what connective tissue diseases do you consider included in group 1, and then what does it mean that vasculitis bullet and there in group 5? How are those two things different?
Oh, I see. You're here.
Yeah, this is
yeah.
vasculitis there. So I get, there's a couple of connective tissue diseases,
Right.
scleroderma or whatever, that I'm going to talk about as being group
Mhm.
1, and then maybe SLE also. Is that what you mean, or is there...
Right. So connective tissue disease generally is referring to scleroderma, systemic lupus, Sjogren's, or any of the overlaps with any of those diseases.
That, yeah.
Yep. Vasculitis is generalized vasculitis that is not those.
Okay.
Um,
Yeah, that's what I wanted to know.
Right, and so I think it's because we just don't know enough about pH in that subgroup of patients to classify them as group 1.
The second question relates to the procedure thing. So when I looked at this a couple of years ago, and I have not looked at it since then, there was a recommendation that in people with PH who are having operative procedures and general anesthesia, there was cause for concern. And at that time, I realized that that kind of recommendation was also being extended to conscious sedation for other procedures. I looked for the evidence, and I thought that the evidence for the surgical general anesthesia thing was weak, and that for the conscious sedation thing was non-existent. I understand the theory behind it. Is there more robust data now?
There is not. There is not.
Okay.
Yeah.
I mean, I understand the theory,
Yeah.
but I also stated the data
Yeah.
wasn't good.
No, and it's not good, and part of it could be that many of these patients aren't sent for elective procedures, if at all possible, probably because of this fear. Right.
Maybe one should just be careful.
So I think that's what it is. And really, and we probably are very cautious, but I think it's because it only takes 1 or 2 cases that have unexpected deaths that, where we didn't dot our I's and cross our T's to kind of make us a little more cautious in this population.
Do we offer the initial genetic screening that you talked about? Do we offer that here? It's not the deep diving.
Right. It's send out, so we have been able to test patients before. We had a patient whose sister died of IPAH, and so we did genetically test her, but it is a send out lab and takes several weeks to come back. But we can order it if we need to.
Are you sending them to genetics with that when you're thinking about sending it, or unclear? Because we didn't have genetics for a while.
Yeah. At the one that I can think of, and maybe there was 2 actually. I don't think one of them was so sick and ended up transplanted, but I think we had sent it because we were so curious about whether this patient had the mutation. But I don't believe we've referred to genetics. It's probably something, if we're testing them, we probably should.
Residency, I've worked as a visiting scientist at the University of California, and we designed a therapeutic platform for pulmonary hypertension at that time. And you ran into the same problem you described here about an adequate animal model to really reflect what's happening to humans. Because with the advances in our pathobiology and understanding of pathophysiology, have there been new animal models that have come out to your knowledge?
There are many animal models, and so there are many ways of inducing pulmonary hypertension in animal models, and also, so not just the mechanism of induction of the PAH, but also different species or strains of animals, right, of rats, for example. There isn't a groundbreaking new way of doing it. I still think what you'll hear at all of the PH meetings is that we don't have a great model. And I think part of that is because I think the human population who has this is very heterogeneous. You may have patients who behave like the hypoxia model, and you may have patients that behave like monocrotaline, and you have other patients that behave like Shugan hypoxia. And so I think we're classifying these patients as being all the same when I think they're a very heterogeneous group of people. Anything else?
Monocrotaline has been around for 50 years, and at least they stopped putting it in grams to expose to humans. We still use it in grams, but really none of the models that we have don't come without reversibility in that. So all the animal models are still something that isn't reversible by removing that. So it still makes it a complete, not incredible model.
Yeah, the other thing I'll add is most of these animal models, once you return them to normal kind of barometrics and normoxia, many of them the pH reverses, which is not what we see in humans, right? So it is a different, it's a different, I think, pathology. Shugan hypoxia is probably one of the most commonly used models right now because we are able to induce both severe PAH as well as RV failure, which you don't get with other models. Mm-hmm.
So I was in dental last month. The echo report there, as assesses the diastolic function of the right ventricle. So other than the morphology, the right ventricle systolic pressure, and the parameters we look for, we have seen everything. You mentioned the right ventricle has diastolic dysfunction grade this. Is the diastolic dysfunction an early
Is it?
injury to the RV before it dilates?
So I didn't include it here, but we know that there are fibrotic changes that happen in the RV in patients who have pulmonary hypertension. And there's some really nicely done PET scan studies that will show that your RV lights up more than your LV in this patient population. So it wouldn't be, so it's expected that they would have a degree of diastolic dysfunction there. We don't report, I believe, diastolic parameters in the RV here. Right. Okay, thank you. All right, so for the next hour, what we thought we would